say so.
Good afternoon, everyone, and welcome to the Cumberland County Board of Commissioner regular agenda session for May the 11th, 2023. At this time, I will call on Commissioner Marshall Faircloth for the invocation.
Let's stand, please, as we honor God and country. Almighty God, we ask your presence among us today, that we might do the things that you would have us to do, that we be pleasing in your sight, pleasing in the eyes of those whom we wish to serve. We ask these things in your name. Amen.
Amen.
I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Commissioner Faircloth. At this time, I will call for approval of the agenda. Manager Greer, are there any changes to the agenda?
No, Madam Chairwoman, there are no changes to the agenda.
move for approval. Second.
Second. If I can get a motion.
Move to approve the agenda.
Second. Second. It's been moved and properly second. All those in favor?
Commissioner Jones, unanimous.
Thank you. We'll now move on to the approval of minutes, and we have no minutes, so we will move down to our presentation. Manager Greer, if you would introduce the item and the presenter.
Yes, good afternoon, Chairwoman. We have two presentations. The first presentation is the 2023 County Health Rankings Update. Dr. Jennifer Green will provide an update of our ranking for the past year from the University of Wisconsin rankings.
Thank you.
Is there a vibration?
Good afternoon.
Good afternoon.
Dr. Green.
Good afternoon, Commissioners. So I'm here today to present to you the 2023 County Health Rankings. So these rankings are released annually, and it is released by the University of Wisconsin and the Robert Wood Johnson Foundation. These county health rankings are based on a model of community health based on several factors. Our two primary factors are health outcomes, which are based on our health behaviors and clinical care, and our health factors, which make up another portion of the ranking. They combine more than 30 different measures to help us to understand the picture of health in our community. And I'll note that this is really just a snapshot of health in our community. And I'll note that the measures used for this data collection are primarily from 2019 to 2021. So we won't know the full impact of the pandemic until future rankings, because it doesn't capture a lot of 2022 data. So our county health rankings are, and I'll show you the numbers in just a moment, but we rank them into quartiles. So Cumberland County ranks in the lower middle quartile for that first measure, health outcomes, and we're ranked in the lower middle quartile. For health factors, we're also ranked in the lower middle quartile. As we noted in previous years, there's been a de-emphasis on the number of the rankings. They rank nearly every county in the country, and there's a de-emphasis on the actual number of the ranking, because if you look, there's a ranking of 1 doesn't necessarily mean a statistically significant difference between the ranking 1 and ranking number 2. And I'll show you an example of that as we go through the presentation. And it's much more important to look at the trends overall than to look at the actual number. But this is the part that everybody wants to know. So our health outcomes are divided into into two different measures, length of life and quality of life. So I've highlighted for you on the screen the areas where we've seen the biggest changes from 2022 to 2023. So on the right-hand side, you have the 2022 ranking, and then in the middle column, you have that 2023 ranking. So in terms of our overall rank, we're ranked number 68. This is a drop from ranking number 52, where number 1 is the healthiest and number 100 is the least healthy. So we rank number 68 out of 100. The biggest difference in terms of health outcomes is under quality of life, and I'll show you where we've made that difference in a moment. And we went from number 49 to ranked number 69. In terms of our health factors, we are ranked number 64 overall. That's an improvement from number 70 to number 64. And the biggest changes we've seen are in the health behaviors and then in clinical care. And I'll show you some examples and the reasons why in just a moment. So this is that quality of life ranking. So remember, we went from 49 to 69. This measure is really made up of a couple of different measures: poor physical health days, the number of poor physical health days in the last 30 days, the number of adults reporting poor or fair health, and then our percentage of low birth weight babies, and then our poor mental health days. So we actually saw improvements in the number of adults reporting poor physical health days, meaning they had fewer poor physical health days in the last 30, and the number of adults that were reporting poor or fair health. We didn't really see much of a change in our low birth weight babies, but here's where the difference really lied and really contributed to the ranking of from 40 to 69. Our number of adults that reported, the number of poor mental health days in the last 30 days went from 4.5 days to 4.6 days. So that difference is not a meaningful difference, right? So 4.5 to 4.6 days, but that really dropped us from the top of the ranking to a lower middle ranking. And that was the driver of that drop of quality of life measure. In terms of health factors, we continue to rank high in terms of sexually transmitted diseases, teen birth rates, adult obesity, and adult smoking. Our food environment index, that's our healthy environment, so our food deserts, how many healthy restaurants, how many grocery stores do we have, how many fast food restaurants, that index is worsening. But we did see improvements to opportunities for adults and kids to exercise, the percent of adults that are physically inactive, and excessive drinking. It does take time to see changes in the metrics. So for example, we saw improvements in our excessive drinking. We have fewer adults that are drinking to excess, but we haven't yet seen the impact on that in terms of death, right? So that takes time. The behavior changes first, and then the outcome changes later. So we have not seen improvement or any significant improvement yet on alcohol-impaired deaths, but because our excessive drinking rates have improved, we anticipate in the years to come we will see improvements in our adult alcohol-impaired death rate. The next factor is our clinical care. So this is, the drivers of this one is about our adults that are getting a mammogram and a flu vaccine. We have not seen a significant change from the previous county health rankings, and for this metric, we still have a lower percentage overall of adults that are getting a mammogram or a flu shot each year. We did make improvements in our preventable hospital stays, so that's the number when people go to the hospital for a preventable reason. We take account of that, and we made improvements in that area, but it still remains high. And then we did make improvements in our number of mental health providers and our number of dentists that we have in the community, but did not make any significant improvements in our number of primary care providers. So these tie in and link back to our community needs assessment. So you'll remember that we do a community needs assessment every 5 years, and we do that in collaboration with the hospital, and our county health rankings are used to inform our community needs assessment. So that's based on primary data like our county health rankings, but also a community survey, focus groups, and other key informant interviews. So our community needs assessment identified 4 priority areas which link back to, you'll see the county health rankings, our economy, food access, affordable housing, food security, substance abuse was another key issue, public safety, including violent crime, and then mental health. And then we develop community health improvement plans to identify in each of those priority areas, how are we going to address those key areas. So I want to highlight a few things from our community health improvement plans and ways that we're working to address the community health rankings, the county health rankings. So first, we identify, of course, that substance abuse and mental health are some key areas for us, particularly around the opioid crisis. So we have the Cumberland-Fayetteville opioid response team. We have 2 outreach workers that are funded with a CFORT grant, and both of those outreach workers really work to identify xylazine in our community early. So as early as last June, they were identifying xylazine in the drug supply. They got early access through NC State to drug testing, and now we have a xylazine test strip that came out in the community, and those folks already have those xylazine test strips in their hands and are distributing those in the community. We also have through a CFORT meeting, we also identified, because of the xylazine crisis, the need for wound care. And so we have mobile unit in collaboration with NC Harm Reduction, Goshen Medical, that happens every other week to address the wound care because of the xylazine crisis. CFORT funds also housed 33 individuals from August 2022 to present. Those are folks that are exiting treatment and need a place to recover, a safe place to recover, and we've used CFORT dollars to do that. Our partners in CFORT also have conducted prescriber training, and they're doing that this month. They've contributed to the distribution of Narcan bags, or medication disposal bags, Narcan. So for example, they're out at the homeless stand down right now, distributing Narcan to folks, making sure they have medication disposal bags, fentanyl test strips, et cetera. We also do smart recovery training. So this is an opportunity, an alternative to Alcoholics Anonymous, just another strategy. And so for folks that are and families that are in recovery, we've used CFORT dollars to get folks trained in how to facilitate these groups. We also have a prescription awareness campaign, and then we've just applied for last month a new round of funding from the Bureau of Justice Assistance that will be focused on children and youth. A couple other pieces and ways we're working to address the county health rankings. We screen for social determinants of health, right? So a lot of the challenges that we see in the county health rankings are related to your health outcomes, which are caused by your income, poverty levels, food insecurity, transportation, housing issues. So we do universal screening for that at the health department. Every patient that comes in gets screened, and then we utilize a platform, an electronic platform called NC Care 360 to make referrals, and in 2022 we did more than 700 referrals to connect those individuals to care to address those upstream factors that impact their health outcomes. In 2022, we also launched a pilot project with, thank you to the commissioners, with Uber Health that allows us to connect people back to the health department for rides for their WIC visit or an STD visit. We'll pick them up and we'll take them back to their homes for an appointment at the health department. We did 125 rides since October, and 30% of those rides were in STD. We know that for many of our STD patients, transportation is an issue, and we note that STD rates remain high in Cumberland County. About 20% of those rides were in our maternal health clinic. We also are addressing mental health, and so we, with some of our COVID dollars, have utilized and done this is a national line. The 988 hotline is a national line, but we really wanted to make sure it's well utilized here in our community, and so we've used some of our COVID dollars, our workforce development dollars, and our school health dollars to do a 988 hotline campaign related to youth in particular, and making sure that they have access to those funding. And then we've also supported Cumberland County schools in participating in what they call a peaceful schools training, which really helps them better address mental health in their schools. We also, with funding from this body, have launched or are working to launch a care coordination pilot project that will really work to address social determinants of health. So that's a collaboration between us and the Department of Social Services. It's a care coordination team that will do case management services in the community and in homes, and we'll hire nurses and social workers and health educators and nutritionists to do that work. We've worked to also increase our STD outreach activities. Again, I'm noting that we have high STD rates here, so we're much more out in the community. Again, for example, we're out at Homeless Stand Down today doing testing. We'll be out at Pride Fest later this summer. And then we also have hired a hepatitis B bridge counselor to connect people that have hepatitis. And then we have a new lab equipment that will allow us to do more rapid testing for some of our STDs, which will allow us for early identification. And then that is all I have for you, and I'm happy to take any questions.
Do we have any questions? Commissioner Booth.
Thank you, ma'am. It's the 2021 Community Needs Assessment.
Yes.
Do we do that annually or every 2 years, 3 years, 4 years?
It's every 5 years. So,
5.
yes, and so we do that in collaboration with the hospital, every 3 to 5 years, depending, we try to get on cycle with the hospital.
Okay, all right. And if you could go back to the panel of numbers.
Yes.
Second or third, there you go. I'm really trying to get the math thing that we plummeted in all this because we went from 4.5 days to 4.6 days.
Yes. So we.
That's like 2.5 hours.
Yes. So, so this is a metric in which where we talk about just because you're ranked lower doesn't make it statistically significant. So most of the numbers are from, for this particular measure, and again, what was really driving that is the number of poor mental health days. So most counties range from about 3 days to 5 days. So every county is somewhere between 3 and 5 days. And so if you drop even a percentage point or a decimal point, that drops you from a higher ranking to a lower ranking. So there's, instead of being, when we dropped from 4.5 to 4.6, there are now 30 counties in front of us that have a number of 4.5 days. And so that was really what was impacting that ranking for our quality of life measure, because we saw improvements in the other measures or no change in the other measures.
Okay, and go back one more
Yes.
to that same thing. There was one on there somewhere, I was jotting them down and it left. Maybe that's not it. There's another one.
Let's see.
It's 40 to 80.
So-
Numbers are 40 and 80. It
So.
wasn't highlighted.
So the 40 to 82, that's our physical environment. That is because last year we had a drinking water violation and this year we did not. And that weighs heavily in the county health rankings. And so that actually was an improvement for us. So the 40 to 82 is the reason, that's the biggest driver in that drop.
Is there another one of these
Let's see.
charts?
I'm looking for, I don't know that there's a 40 to 80 number
I
somewhere.
thought there was 2 pages of the highlighted areas.
Oh, this, are you looking for this one?
No. Okay, maybe it was just the 40 difference between 42 and 82. Okay, that was a big jump for it not to get highlighted. We had 11, 7 to 59 highlighted, 20, 69 to 49, and the 40-point difference of 42 to 82 was not highlighted. So I was just
Yes, I was trying to draw.
what the cutoff point was for making the highlight list.
I wanted to highlight those because those are areas where we needed improvement, and the 40 to 82,
up with what we really stink at is congestive heart failure, diabetes, hypertension, teen pregnancies, and STDs. I didn't notice any of those things that were, and I would think those would be the top reds, right? The top red things that we can, I think what we're finding out is if we can just improve a little bit, it will significantly increase our opportunity to be better in the health rankings. So I've asked this for a number of times, Dr. Green, but why aren't we focused? We're not as bad as we think, because there's some things we're really good at. Right? But we don't highlight those, we highlight the bad things sometimes. But why are we, I would think in 15 years we could have a plan to help with STDs, but we keep putting so much money into STDs, but we're not showing any improvement to mitigating STDs. You know, now we're going to people's houses and so, you know, they're finding a way to get out somewhere. But my point is just to focus on a couple red areas where we could be so much better, and I think it would increase our opportunity. But why hasn't the CHSI looked at those 5 main things for us? That's one question. I'm gonna finish up with one last thing.
Okay.
We get cheated a little bit on this survey. This is out of Wyoming or Wisconsin, right?
Wisconsin.
Right. The county with the highest doctor to patient ratio is, everybody should figure out, it's Durham County, because they have Duke University there. Well, we have a number of citizens who use the federal government for their doctor patient, WOMAC, the clinics out there. So those aren't really counted in our statistics. And so it's not, I am right on that, right?
They're up there in the rankings. Measure for the,
right.
That's the one about the ratio of the mental health providers.
Right,
yes.
right. And so the mental health providers is the same thing.
Correct.
But it's a little bit of a misnomer because we have the military population and retiree population.
Right.
But the docs are being serviced to the federal government as opposed to locally. So it makes us look lower.
Yes, and so that's why one reason I think it's important to know, you know, these numbers, but it's more important to know if we're getting better as a county. So we want to be able to look at our peer counties and say, are we improving or not? But we want to know how we are trending, because we'll never be, we won't have the same number of providers that a Durham County or an Orange County does. But if we are getting better in Cumberland County, that's what we really want to look at.
Yeah.
And the other, I want to differentiate between the community needs assessment a little bit and our health department's strategic plan. So the county health rankings inform both our strategic plan and the community needs assessment. The community needs assessment is really broad, community-wide, with input from the hospital and lots of other community partners. But health department strategic does address, one of our priorities is addressing the STD rate in our community, and we have priorities related to that in our, so this is the priority areas for the community's needs assessment, but we also have a separate strategic plan that we link back to the community needs assessment. But the community needs assessment is really about what organizations across the county can do, and that didn't rise to a priority level overall based on community survey. And we presented all of that health rankings data to them, but it does show up as a priority for us in our Board of Health priorities. One of those is our STD rates, because we know they're high, and as well as our teen birth rates. Those both show up in our strategic plan for the health department.
And it's consistent. It's been for a long time.
It's consistently high, and we, part of it is we have a very young population in Cumberland County. We have a lot of 18 to 24-year-olds, and STDs happen in 18 to 24-year-olds, disproportionately so. And so that's one of the reasons why we're working on those outreach events and trying to be where our young people are. We're going to be, we go to the bars, and we do condom drops at different locations around the city, because that's where our young people are, and try to collaborate with youth serving agencies to really address those high STD rates.
Do you think, real quickly, do you think that our STD rates are higher, to your point, with a younger population, maybe
to go to a military facility as part of their record to show that they may have that?
That can be a contributing factor, but we do, a few years ago, the Department of Public Health on Fort Bragg got into the state's communicable disease tracking system. So before, we had two separate systems for tracking, and now we can, if you, frankly, if you have an STD on Fort Bragg, we'll know about it, and vice versa. And so we can share data better, so regardless of whether you're in the military or not, or affiliated or have TRICARE or not, we can see that. And so those types of things, while it might seem small, help us to track disease much better than we were able to do that. And then, of course, with COVID, we weren't able to do as much outreach, but we're back out, to use a late term, we're back out in the streets again doing lots of different outreach events to address this. So those, I do want to point out that those two priorities, teen birth rates and STD rates, do show up in the Health Department strategic plan.
Okay, thank you.
Any other questions? Commissioner Jones. You're muted.
Can you hear me now?
Yes.
I do have a question in regards to the care coordinator project. When will that start and how long is that project going to be? You were discussing a care coordinator project that's going to take place with case management, the social services.
Yes, ma'am. So we have hired, let me go back to that slide. We have hired we've hired the supervisor for the health department. So it's a collaboration between us and DSS. We've hired the health educator, a nurse, and some of the supervisory staff. A few more staff are starting in our next orientation date, and then they're finalizing some forms and consent forms, and then we'll be able to start seeing clients before the end of the fiscal year.
Okay, and another last question is, I know the data that came from, you said the Robert Johnson organization on Lewiston, here in North Carolina. I was just wondering, do you all have a breakdown percentage? Do they go by geographic area, and also the data that you all take? Does it break down area in reference to like income and minority, as well as age, and some of these that we're discussing? As far as like the health behaviors, clinical care, when you all do your assessment strategy, do you all have like a breakdown of the specific areas, like as far as basically the income of these individuals, and the minority ranges of like 50% or 30% African American? Does any of that included in these studies when they're going to research?
Okay, so if I think I understand the question, so every ranking, there are 30 different measures. Every measure is not broken down by race, ethnicity, but several of them are. And in the interest of time, I did not do that. But in your handout, you have a printout of all of the county health rankings, and we will send the link out to you. And if you play around with the link, you can click on them and then see the disparity by race, ethnicity for the measures in which the data is available. And then I think the other question was about age. Some of those are not broken down by age, but some of them are age specific. So for example, our teen births are, of course, teen birth rates some of them are adult only measures. So smoking is adults only, mammograms are adults only. And then, and can you repeat the last part of your question if I didn't answer it?
Unnatural, like the income of individuals in minority, or income like low income, or when they're doing the studies, low income, or is it a variation? Now they do some county studies where everyone receives it, or are these specifically given towards certain geographic areas, like low income areas of Cumberland County, or is it a variation of Cumberland County? So, I was just wondering.
So this is, yes, so this is all county level data. There, some of the measures break down, as I said, by race and ethnicity, not all of them. And if you click on them, we'd have to go measure by measure. Some of the measures are probably not on the website, but they do have an income breakdown to say whether or not it is impacted by low income or some other social vulnerability index measure, but we'd have to kind of dig into the data a little bit more, and we can certainly send that to you.
Okay, thank you. That was my question.
Okay.
Thank you very much, Dr. Green.
All right, thank you.
We will now move on to our second presentation by Justice Services Manager Griff. You will introduce the item and the presenter.
Yes, Madam Chairwoman, Courtney McCollum, our recent hire for the Justice Services Director, is going to provide an update of the activities they've done since she's been here.
Thank you. Good afternoon.
Good afternoon. Again, Courtney McCollum, Director for Justice Services. It's going to be a very quick presentation. We want to kind of take you guys on a little small map of where we are now and where we are planning to go in the future. Of course, Justice Services, formerly known as Pretrial Services, consists of our pretrial services, our sobriety treatment court, also misdemeanor diversion program, and also the coordination for our Juvenile Crime Prevention Council. In January 2023, I was hired as departmental director. That particular position had been vacant for almost 2 years, so therefore there was an existing staff serving as interim in that position. Things were moving as they normally would be in pretrial, and so with that, coming into a new position, new staff, had to work with the staff morale and also working to kind of move things through the process. We also needed to work on some of our budget management in order to push some of our programs through the process of meeting and exceeding their goals. So what we have done since January, of course this is May, and like I stated, I made it to this point and very excited about the work that we have done. So we have had a business service process review with our ITS department to assist us with research and databases needed to promote our current needs. The systems that we were using or are using in pretrial are pretty outdated, and so we needed to do a rehaul of those processes so that we can improve our work process flow. Justice Services is a staff of 9, a very small department within Cumberland County. Staff, they're, as I stated, different divisions, and so sometimes that can form silos in the way that we work. And so what was important for us to do, because pretrial is very time sensitive, and because we assist the detention center in decreasing their numbers, it is important that our staff is flexible, nimble, also being able to react in order to get the individuals out of the detention center so that we can make room for more people. And so in doing so, we needed to cross-train our small staff in order to fill all roles within Justice Services. So if one person is out, there's always someone there that can go and do a release or do an OFA on individuals. So because we're a small team, we need to work together in order to move that process. We have also revised and also created new policies and procedures for our programs and also staff as well. As of today, we have submitted 4 grants. One is a new initiative, which is our Safe Haven unsupervised visitation. We have provided or submitted 3 grants for enhancements of our specialty treatment or recovery courts. Currently, one of those specialty courts, which is adult drug treatment court, is unfunded. So this funding would provide them the resources they need to continue the work that they do. 3 of those grants were for existing, 2 of those grants were for existing specialty courts that are currently funded, but their funding expires June 30th. And that's our Veterans Treatment Court and Worth Court. Lastly, we're working on branding and marketing our programs. A lot of people are still calling us pretrial services, so we're trying to change the language to let everyone know that we are justice services. This is our mission. We're going to serve as the umbrella for Justice Evolved initiatives for Cumberland County. So what we're planning to do, we are planning to work on our national accreditations. We want to get staff professionally developed in order to be able to provide our services. Also, look at best practices of other pretrial and justice services models so that we can be the best in the state and then hope international in about 5 years, maybe. Also, we will look to expand the current services of justice services. So as I stated, those things that we're providing now, but we want to expand our specialty recovery treatment courts to consist of all those courts that pretty much provide the same services just to specialized populations. We also are going to continue to find and apply for additional funding in order to leverage our services that we currently offer now. Any questions?
Are there any questions? Okay, there are no questions. Thank you so much and welcome.
Thank you.
Now, we will now move on to consideration of agenda items. Manager Greer, if you introduce the item and the presenter, please.
Yes, last week, Madam Chairwoman, when the Crown Event Center Committee met, there was a recommendation made for the budget and the project scope for the Crown Event Center, and we wanted to bring that forward to the whole body of the county commissioners so they can see it and have approval. Brian Haney and the Crown Event Project team will provide the presentation and go through the particulars of the presentation.
Good afternoon, Madam Chairwoman and Commissioners.
Good afternoon.
I'm here today to provide you with an update on the proposed building program for the Crown Event Center and an updated cost estimate based on the recommended program. This went before the Crown Event Center Committee last Wednesday, and the committee made a recommendation regarding the program and budget, but also wanted the full board to see all of the information that they were provided with at the time. Some of you have seen this information before, and others are seeing it for the first time, as is the public, so I will try to be as concise as possible, but please interrupt me if you have any questions or would like to discuss anything in more detail. We do have members of the project delivery team here who may be called on to help answer questions in their area of expertise. So this project began with the 2021 CSL Market and Financial Feasibility Study, which recommended the construction of a multi-purpose event center to replace the existing Crown Theater and Arena. That study provided an initial program recommendation of 89,000 square feet and a budget for that program of $80 million. The current approved project budget is $82.5 million. And since that initial budget was established, again, several years ago, we have experienced significant escalation and unprecedented inflation. Also, Ewing Cole was hired as the project architect this past November, and they quickly began meeting with project stakeholders to determine what they wanted to see in the new facility. These stakeholders included community members, current users of the existing Crown facilities, and county commissioners. From those meetings, Ewing Cole developed a stakeholder requested program of just under 132,000 square feet. This notably larger program, this is notably larger than the original CSL study program. However, there are some significant elements that were included in this program that were not included in the original CSL program, resulting in the increased footprint. Among those are a larger performance space that can accommodate 3,000 people, additional VIP spaces designed to enhance the patron experience and generate additional revenue, as well as additional meeting and event space that can be rented out to allow for multiple events to occur at the same time, which would also provide additional revenue generating opportunities. From this larger stakeholder requested program, the project delivery team reviewed the requested items and discussed which of those items might be nice to have, but ultimately were not necessary for the successful operation of the new Crown Event Center. Some of those items included some of the smaller meeting and event spaces, which the idea was that the larger areas could be subdivided to accomplish the same goal and serve the same need. Some additional VIP spaces, like a speakeasy type lounge that was deemed as something that would have been very nice to have, but also not something that was required. And then some additional ancillary space that was determined just not to be essential to that program. So these items were removed to arrive at a final project delivery team recommended program of 122,955 square feet. This is the program that the Crown Events Center Committee recommended moving forward to the full Board of Commissioners. And you can see here how these different programs stack up against each other. Ewing Cole has also generated an initial concept rendering on the site based on the new program, and here you can see a view of that rendering from the corner of Gillespie Street and Otis F. Jones Parkway. We also had the owner's representative, MVP, and Ewing Cole work together to develop a cost estimate for the different program options. The first budget on the left side represents the original project budget of $80 that was approved based on the CSL study program. There are some elements that are not included in that original budget, such as your FF&E is not broken out, but it also does not include escalation. The next budget of $127,725,900 is for the recommended program of 120,000 square feet that was moved forward by the project delivery team and the Crown Events Center Committee. This budget is designed to take into account escalation through the midpoint of construction, which is standard. The final budget on the right of $131.7 million is for that stakeholder requested program I mentioned of 131,500 square feet. The cost per square foot is included at the bottom of each column. I do want to stress that when you take inflation into account, that cost per square footage for the original CSL study program comes in very closely to the recommended program cost per square footage. Before I turn it over to Vicki Evans, our General Manager of Financial Services, to go over the financial model, I want to see if, Jermaine, do you have anything to add about the square foot, cost per square footage, or?
Well, just that based upon data, conference, construction
Jermaine.
prices.
Yeah, they want, microphone helps.
Just that data coming out of the latest North Carolina Construction Conference, construction prices are up almost 32% going back 3 years ago.
Thank you. Commissioner Booth?
If I was wearing a hat, I'd tip my hat to Brian and the committee and everybody that had input on this. We don't have a good track record on sticking to a budget, so the difference of $4 million to go with what the stakeholders want, I don't think that 127 is going to come in, I don't think 131 is going to come in, but I think it's more justifiable if we say, this is for everything you all asked for. So I would be more inclined to do the 131 now, cut it. We're not going to be able to come back in 10 years and do the tweaking to the little rooms or put 2 more skyboxes in. This is going to be up there for decades, and $4 million. I mean, no, not to belittle $4 million, but all the other projects we're talking about is in the hundreds of millions of dollars, and we don't blink an eye. So for the community, we asked for their opinion. They gave it to us. It's a $4 million difference. I think the group did a good job paring it down, because I think we should have stayed around the 131.
If I may, I'll let Vicki talk about the affordability, and then that's a conversation that we can certainly talk through as well.
Thank you, Brian, and good afternoon, Commissioners.
Good afternoon.
Okay, so the clerks are handing out the model that was shared at the committee meeting on May 3rd, and they're also handing out an additional model that was run after May 3rd. The reason we ran another model was to perform due diligence, because within the model that has the date of May 3rd on the top right, that model and the model where we modeled out the $131 million project, those models are based on paying back the debt over 25 years. And so when DEC, our financial advisors, prepared these models, it was a norm for enterprise fund related projects to be allowed to have 25 years of debt payments. And so a question came up about the LGC and them approving debt over 20 years instead. And so that's why we ran the model at over 20 years at $127 million, and it does work in that model. The $131 million did not. We did not go below zero fund balance, but we did get into fund balances below the 0.25 that is set according to policy. And so what DEC advised was that they feel very confident that they can make an argument for a 25-year debt issuance, and they have many examples of projects that have been issued over 25 years. One's very similar to this one, and the LGC approved. According to them, there's conservative people on the LGC now. And so they can't guarantee, and regardless of who, be able to guarantee what the LGC is going to do. And so in terms of risk, the $127 million is the safest amount to move forward.
Are there any questions?
Oh, yeah.
Commissioner Keefe.
Thank you. First of all, why do you even bring it to the committee to vote on and then give us something else for the full commissioners to vote on? I mean, it's not, we voted on this as a committee to bring it forward, and now there's different information that we have to go all over it again. And if it's an LGC problem, why didn't we know about that before we started doing all this? I mean, why did we change? It was just 2 or 3 days ago we had this meeting.
We changed because a question came up about the number of years that the LGC.
I raised the question, Commissioner Keefe, just based on my experience with the LGC and then looking at the model. I wanted to make sure that we didn't get caught when we got there and they say 20 years. Now, with that being said, there's still we could still do it over 25 years if we do initial 20, if the LGC says that you only can finance it for 20 years, we can do initial period and financing for 20 years and do the additional 5 after we get to the additional debt issuance for additional 5 years.
So added on the end?
Added on the end.
Okay.
So if I asked that question, just wanted to make sure that based on the makeup of the LGC and previous experience with the LGC, we can get called down there and they can deny the loan, deny the funding. So I wanted to make sure that we had both and then we presented with both. And I raised the question after the meeting, and that's on me. So.
Well, I do appreciate that, because at the end of the day, it is the LGC. I get it, but I mean, if that's what the LGC has been doing, they didn't all of a sudden just stop. But regardless, I do want to point out to the group that by admission and design of the staff, these are incredibly conservative numbers. These numbers are based upon a slower growth rate than has been happening in the last 2 years for things like food and beverage, for things like local occupancy tax. And this also takes into account that the county will 100% finance this thing without any private contribution, without any naming rights, without any grant money. And Glenn, you might need to help me out on this. There was a pretty significant escalation and contingency on this, wasn't there?
Yeah, it was a contingency.
Yeah, the contingency. What was the percentage of the contingency? It was pretty high.
There's multiple contingencies built into the budget, and so those are shown, shown down here what the percentages are, but the owner contingency is up here, and it's based on 5% of construction.
Right. And 5% doesn't sound like, but when you're talking about a $125 million project, 5% is a significant number. It seems like there's a pattern sometimes where we vote on something and we think that it's ready to go, and then we come to another meeting and it's changed. And it took about all my mental capacity bandwidth to figure it out last time, and now I had to do it again. So if I can just wrap this up. Based upon 20 years, if we only went 20 years without any sort of mitigation on that, you're telling me 127 works, but 131 does not.
Correct.
But if we were to have 25 years, 127 works, 131 works, all the way up to whatever.
Yes.
Okay. All right. Okay.
Any other questions, Commissioner Booth?
If we do the 120, it never happens to us that our builders come in and tell us that there's been a change order. Does that automatically mean that we screwed up when they all of a sudden send us another 2.2 million, or they're going to have to leave because something's come up and now we're at 129, 130? Have we screwed up, or do they take into account that you don't know what eggs are going to be next week? I mean, that's, you know.
So the type of contract that we're going to issue is a construction manager at risk. And so the budget that is provided to that contractor, they're going to have to adhere to unless the owner wants to make changes.
Right, guaranteed price.
Yes.
Like if we wanted to be safe and ADA compliant and stuff.
Well, hopefully that'll be included in the beginning.
Any other questions, comments?
I think y'all did a great job.
Okay, if I can get a motion.
I'll make a motion.
Thank you.
Because I do.
It's your baby, that's why we.
Well, thank you, and I appreciate that.
You pay for it.
Or our kids will.
No, you pay for it.
Okay, I believe in this community, and I believe that they deserve this facility. I don't want to go into this project under budget without having all that we can have. I've looked at these numbers deeply, and I understand how conservative they are, and I believe that we're still on solid ground, and with the manager being able to negotiate even if we have a 20-year LGC term. I'd like to recommend that we approve the $131 million. Oh, God.
It's like 3 or 4.
All right. I stand by everything I said before, and now I'll just go to this. Is it the 130?
It's all of those approvals right now.
If I may, that recommendation is based on the recommended program, not the maximum program.
Okay, what is the maximum number?
All of those approvals right here.
Yeah, where's the
The
maximum?
maximum program is 131,445 square feet, and that project budget related to that is $131,703,300.
131 million, what was it?
703 $131,300.
Manager Greer, did you have something to add?
Yes, I would just say that 131, although it may not be achievable, or it may not fit the model just for the Crown, in the near future, we'll have additional tax revenues or revenues that we can contribute to make sure that the project is whole.
Thank you.
Okay, Commissioner
Okay.
Keith, your motion.
All right, thank you. I make to approve the Crown Event Center Committee's building recommendation of, that was 131.
131,500 square feet.
131, no, I'm looking for square feet.
131,500 square feet.
131,500 square feet. Approve the capital project budget ordinance number to appropriate
Additional funds.
I would like to make a motion that we have a budget of $131,700,000 for the Crown Event Center project.
Was that the whole motion?
The motion doesn't work. I mean, there's so much going on in there, but my motion is to have a budget of $131,700,000 for a 131,500 square foot Crown Event Center.
But I would ask Vicki, do you need the budget amendment that's in here?
Okay, so what can happen is I can adjust the amounts in that budget revision and keep that same number, and your motion with the dollar amount, I think, should be okay.
Does that work, Attorney? Okay. Okay. That's my motion, Madam Chair.
All right, it's been moved and properly second. Commissioner Fairclough, do you have a question?
Yeah, discussion on the motion. Is this a motion to move this to the Monday night agenda? Is that what the motion is?
Yes.
Okay.
To the consent agenda. If it's
To the consent agenda.
If it's
Yes.
unanimous. If it's unanimous.
Okay, it's been moved and properly second. All those in favor?
Unanimous.
Thank you.
Thank you, Commissioner.
Thank you.
We will now move on to item 4B. Manager Greer, if you would introduce the item and the presenter.
Yes, it's the Chaplain Hall contract amendment. Brenda Jackson, Interim Social Services Director, will provide an overview of the contract amendment. It deals with foster kids that are aging out of the program and/or transitioning to adulthood.
Good afternoon, Madam Chair and Commissioners.
Good afternoon, Ms. Jackson.
Our model approach for change initiative to improve and reduce the number of kids we have in foster care. We have maintained this relationship with Chapin Hall with the University of Chicago for the last 5 years. They've been working with us on consultative services, data analytics, and other services to help us to look at our internal services and how we can wrap around the resources within social services to improve aging out kids in foster care, as well as working with our external partners. We've done extensive work with our court system, delinquency in schools. We're proud to say in the last 5 years that we've been in this project, of the 8-year project, that we have been able to successfully, with the great work of the social work staff and all of the community partners that I just mentioned, we've been able to reduce the number of kids in foster care to over 900 kids, to now we have a little over 560 kids in foster care. We received additional monies from Duke Endowment and some unused money in the contract because of COVID travel restrictions, and we would ask for a budget amendment to include those dollars to continue the work, and that this item be considered for your May 15th consent agenda.
Are there any questions? If I can get a motion.
Move to amend the amendment on the Chapin Hall contract.
Second.
It's been moved and properly second. All those in favor?
Unanimous.
Thank you.
Thank you so much, and thank you for the support of this work.
Thank you. We'll move on to item 5. Are there any items of business?
No other items of business, Madam Chairwoman.
Okay, we will move on to our monthly report. I'm sorry.
Oh, sorry. There was one other item of business, I'm
Okay.
sorry. Vicki Evans will go over a resolution regarding retirees' health insurance.
Okay.
Okay, so the clerk is handing out a document that's a resolution about retiree health insurance. And so what you have in that packet, stapled to the back, is the resolution that got approved back in 2020. So since then, the county has had opportunities for retirees who have been on the retiree health insurance plan return to work full-time. And when they do that, it puts them back on the active employee plan. And based on the wording of the original resolution, this does not take that into consideration. And so today, this resolution, and so Rick wrote this resolution up for us. This will allow any Cumberland County retiree who is or was actively enrolled in the county's group health insurance plan for retirees and comes out of retirement to return to work for Cumberland County full-time shall remain eligible for retiree health insurance benefits upon their subsequent retirement. And so we're asking that this be moved forward as a consent agenda item on Monday, May 15th.
Are there any questions?
I'll make that motion. Is this a problem?
Is it a problem?
I mean, do we have a number of employees that have retired and come back?
We have one person who is actively employed as a full-time employee who had formerly retired,
Yeah.
and we have someone else considering it.
Okay. Okay, so the motion that you're looking for is just to approve the resolution?
Yes, sir.
All right, make that motion.
Question on the motion, real quick.
Well, I'll second it just so we can get to that point.
Commissioner
Go ahead.
Booth.
Yeah, it's, even though it doesn't have all the terms of A through E as the 2021, this is in addition to that, like they still have to pay the 100% of any employee costs and stuff,
Oh, yes. So subject to
the 2020 memo, resolutions.
This is inserting this language to the 2020 resolution.
Doesn't change it, okay.
Doesn't change it,
All right.
just
I didn't see anything down there, it says they can just have it.
It says that they must pay 100%.
That's the 2021, that's what I'm saying.
Yeah, but,
Everybody does. Yeah, everyone has to pay
yes, everybody does.
the premium.
oh, the employee portion.
And I guess everybody's got a labor shortage, so as we try to call some of these folk back,
Great idea.
this in turn helps HR be able to benefit, because I wouldn't come back if I couldn't do that either, so I would
Yeah.
be in favor of the motion.
And in a few more years, Glenn will be nearly in the shape he is now, so this will be something he'll really be looking forward to. Yeah, he'll be looking forward to this.
Okay, it's been moved and properly second. All those in favor?
Unanimous.
Thank you.
Thank you. Okay, our monthly reports, we have already reviewed those items. So we will now move on to our closed session. If I can get a motion to go into closed session.
I move to go into closed session pursuant to NCGS 143-318-11A5, I'm sorry, for our real property acquisition.
Second.
It's been moved and properly second. All those in favor?
I'm sorry.
Thank you. We will now go into closed session. If I can get a motion to come out of closed session.
So moved. Second.
Chair. If I can get a second.
Second.
Favor?
I don't know what she did. You zoomed in, Veronica. There you go.
There you are. Okay, I move Richard.
Second.
It's been moved and properly second. All those in favor?
Yep, she's frozen.
You freeze with a hand?
She's frozen.
Commissioner Jones?
She could be a guard at Buckingham Palace.
Thank you. Thank you.
That's weird. With only one person up there, it's like odds.
Council? Thank you.
Why?
Yes, yes, you got it.